And since we are running late a little bit, I would like to switch for my very good friend, Dr. Bhaskar Somani. Very nice to see you, Bhaskar. And you will talk about single-use flexible ureteroscopy for children. Even we know that it's not a very frequent situation, but children are very demanding. So we listen to you, Bhaskar.
Thank you very much, Olivier. It's a real pleasure for me to be here amongst a lot of endourologists I've always looked up to. So it's a real pleasure to be here. Thank you, PUSEN, for this. I have been doing pediatric ureteroscopy for last 10, 11 years, and I have to say it is challenging, not just because of the size, but also you have the compromise. The kids can decompensate quickly. You have the parents, and the decision making is also quite important. So far, there is no obvious study on single use in children. So I'm going to share my experience. This is my conflict of interest. So looking at the guidelines, the EAU guidelines, the indications for children are very similar to adults. Ureteral stones under 1 centimeter, you have lithotripsy with ureteroscopy as an alternative. And renal stones, again, up to 2 centimeter, you have lithotripsy with ureteroscopy as an alternative. And large stones, of course, we all agree that PCNL is better. It's important in pediatric to offer metabolic evaluation and especially to try and analyze the stone. Now, for flexible ureteroscopy, particularly, the stone-free rate is reasonably good. Retreatment rates can vary up to 20%. Complications generally have come down and they are minor if they are. But they're especially useful for low pole stones with unfavorable anatomy. And the failure predisposing factors for failure are young age, cystine stones, large stones, and lack of pre-stenting. And that's where I think the smaller single-use scope comes in, because you don't have to always pre-stent, and you can get up probably easier in younger children. And compared to PNL, yes, the stone-free rate is slightly lower, although you can stage the procedure, but you have less radiation, complication rates are lower, and of course, a shorter hospital stay. So worldwide, we know that the trend of ureteroscopy is increased and lithotripsy has come down, and it's the same in children. And when we look at the publication trends, it shows the same. Ureteroscopy and minimally invasive PCNL have really taken up even in pediatric patients. So looking at our own data, bearing in mind, we didn't have a small enough single-use scope so far. So I have tried to use it, but even that slight increase in diameter, I've so far used reusable scopes, but going forward, I would be using the 7.5 PUSEN scope. So we had 81 patients with 102 procedures with a mean age of about 9 years and a stone size of 9 millimeters. Location mostly in the kidney, of which most in the lower pole, as you would expect. Multiple stones in more than a quarter of patients. The pre-op stenting, we get patients from a wide area, almost 200 to 250 miles. So some of them are pre-stented before they're referred. The post-op stenting rates are generally lower than what you would expect in adults. And we are not afraid to use access sheets, but I try and use the smallest possible, which is the 9.5, 11.5. And this is the key, the stone-free rate, the final stone-free rate. Some patients did have a second procedure, was quite good. And complication rates, we had 1 sepsis and respiratory issue and 2 UTIs. But this, I think, is the key point, that ureteroscopy in pediatric patients is now very safe. In fact, I hope that in time we see them poised equally with lithotripsy when it comes to pediatric stones in the guidelines. And how do we do it? We have a twin surgeon model, and I think I'm not good in looking after kids because that is not my bread and butter. So we pair up with pediatric urologists and we jointly discuss these cases, we plan them. They're seen and managed by the pediatric urologist before and after, because they have a team of pediatric nurses and the whole team who are used to looking after children. We do the procedures jointly. And as I said, it's an excellent outcome. And I know a lot of UK centers and European centers are adopting this model. So looking at the use of access sheet, because this is something we have talked about. Recently, we have teamed up with Spain, and this is our results for 48 patients using access sheet in pediatric patients. Generally speaking, the mean stone burden was more than 1.5 centimeters. So large stones and a third of them were also multiple stones. We use the 9.5, 11.5 access sheet across both centers. I'm hoping with the 7.5 scope, these sheet size can come down further. Now, when we look at the surgical outcomes, again, the stone-free rate, although some patients needed a second procedure, the stone-free rate was 100%, and the complication rate has really gone down. There was one minor ureteric injury, and there was one UTI, but really more than that, all patients had good outcomes. So I think if you need to use access sheets, especially for large stones in pediatrics, don't be afraid, provided you are safe and careful. Going forward, what about the long-term effect on pediatric access sheet? We don't know. We are always worried. Could there be stricture formation? So we looked at our series of 21 patients. This was published a few years ago now, with a mean age of 12 years. And again, reasonably large stones, access sheet, as I said, this is what I've used. The pre-op stent rate was low, and the complications, we had 0 complication in this, and one patient wasn't stone-free. And this was over a period of just over 2 years in a mean follow-up. So I think the risk of stricture formation, and I know from Prof. Trax's data as well, it's quite low, even with complications. So without complications, if you have not had a ureteric injury, that risk is minimal really. And we didn't find any strictures. What about comparison with other forms of treatment like mini PCNL? We compared our center where we specialize in ureteroscopy versus a center in India who specialize in mini PCNL for pediatrics with comparable patients. They had slightly higher stone size, but we had more multiple stones. But overall, the details in terms of stenting, nephrostomy, etc., were similar. Stone-free rate 100% for us, 97% for them. Complication rates, again, slightly higher for mini PCNL, but they were all minor. So overall, there's no difference. And that landscape will change further if we had smaller scopes, for sure. Looking at ureteroscopy for stone disease, what is the watershed? This is a very important paper and a table. 6 years seems to be the watershed. If the patients are over the age of 6 years, the failure to access rate is much smaller, and the complication rates are less than a third. So what if we had a smaller scope? The failure to access rate will improve. You can do primary ureteroscopy. The complication rates, for sure, because a lot of these mucosal aberrations and so on will come down. So again, there is a good argument to be using the smaller diameter single-use scopes for these patients. What about lower pool stones? We know that they are almost in parallel with the adult literature. This is a recent paper again in 2 European centers looking at lower pool stones. We had 57 patients with a mean age of about 10 years. Again, about a third of them had multiple stones. This is important because, again, not everybody needs pre-stenting. About a third were pre-stented, and some of the post-op stents was either a stent or an open-ended ureteric catheter overnight. Access sheet we used more often in this cohort. The stone-free rate, again, was quite good. You have to warn the patients or the parents in this case about a need for stage procedures sometimes, and the complications related to urinary tract infections. And I think, again, for lower pool stones in pediatrics, especially if the scope size, as my friend Guido has showed, so the small size, it's easier to deflect, it's easier, and probably it'll be easier to navigate. So I think, again, the feature of low pool stones with smaller scopes would be a lot better. Now, this paper has already been mentioned by Guido, but I think this is the only one that compares the small size PUSEN scope to the standard size. And they had 15 patients in both arms, smaller access sheet for the smaller scope, but there was no difference in terms of vision and maneuverability. They were very similar. And I think the advantage with the small size would be that you can introduce them through smaller access sheet, and the vision, deflection, and the ability to maneuver is very similar. So again, why use a bigger size if you can do the same job with a smaller size, which has an advantage of less mucosal trauma or more primary ureteroscopy? Total fluorolysis is something that has been published from Spain. I don't particularly practice this in pediatric patients, but I think if you're good in ultrasound or you've got access to it, you might do it. I feel a bit nervous. I always like to see when the access sheet is going past the ureteric orifice and around the UPJ, but they have got indications for when they would use fluoro, but otherwise they have said, Emiliani and Anna B. Jones, that you can do it fluoroless. And if you can do it safely, then why not do it in pediatric patients and minimize radiation dose further? What about a combination of like an ISRS, a mini PCNL, and with Flexi-ORS? Again, this is the only paper I could find, and you could potentially do it. And the advantage of small scope is you can combine them with micro PNL or mini PNL and treat multiple stools. Although I have to say the indications for ISRS, in my view, for pediatric patients would be very, very limited and probably not as justified as in adult patients. And this is something that probably is best served for multiple stools. Although if you've got a smaller scope, then and you can access it, again, you can treat them through the ureteroscope itself. This is something that people talk about with should be the size of a volume, who should be doing pediatric stools. And we looked at medium and high volume centers, and we defined medium volume as between 25 to 50 cases, which they were reported, and high volume is over 50 cases. And actually, there was no difference in these medium and high volume cases, and ureteroscopy was safe and effective in both of these groups. Clearly, if you're a low volume center, you should be referring them on to a more experienced center. But if you do a reasonable number of pediatric cases, because it's not just the surgical ability, it's also looking after the patients before and afterwards. And that's why I think the volume is important, and teaming up with the pediatric colleagues is also important. The high-powered laser, there's the worry about temperature and so on. And we looked at the dusting and pop dusting using a high-powered laser. And actually, with dusting and pop dusting, you start with dusting, and then you move on to pop dusting. So start with the dusting setting, go on to pop dusting setting. And even though this was a small series, we didn't find any complication, and there was no issue. Clearly, we didn't measure the temperature, and that is something I hope the modern generation single-use scopes can incorporate, how to measure pressure and temperature at the same time. So 10 years ago, I thought, well, I can't do it. It's really difficult, but actually you can. And how do I do it? You have an up-to-date culture, ultrasound imaging. We predominantly use ultrasound for all the pediatric patients before and after. Antibiotic prophylaxis guided by culture or as per your protocol on the resistant patterns. Initial cystoscopy and safety wear, and I always do a semi-rigid with the needle scope. And that is because you can calibrate the ureter, passively dilate it, and you can see whether an access sheet will go, and if so, only then use an access sheet. Otherwise, you can do a railroad with the primary ureteroscope. Access sheet is always, for us, is the smallest available. And so far, we have used a reusable scope, but we are planning a study with the 7.5 French PUSEN scope, and I hope that changes the landscape for pediatric as well as the difficult ureters going forward, even in adults. And always in pediatric, keep the irrigation pressure as low as you can and the operative time as low as possible. I think these two are fundamental. Overnight, we tend not to do it in day cases and keep them overnight, but most of our patients go home the following morning. So where is the role, I think, of single small use ureteroscopy? I think smaller scopes leads to less pre-stenting for sure, less, more primary ureteroscopy, less post-op stenting, higher success in pediatric patients. And then I think if they're single use and readily available, even with centers who don't do it that often, probably are going to start doing it. But you need to be doing a certain volume of these cases. I've used it in adult cases, in a very difficult adult case, and it went really well. The characteristics have been beautifully covered by Guido, so I'm not going to go into that, but I think there is definitely a shift towards smaller scopes with this in market, and it will drive probably technological advancements further with smarter scopes which can monitor pressure or irrigation or temperature. So I've used it. It was very comfortable. I agree. It's very lightweight. And it doesn't, once you're doing it, it doesn't feel any different with any of the other scopes. Thank you very much, and looking forward to the questions.
Thank you, Bhaskar, for this beautiful overview regarding pediatric and flexi. This is not so common. We don't do so much. I think you made a very important comment, this collaboration with the pediatric surgeons. In many countries, adult urologists, they cannot treat stones from the children. They need to collaborate. That's exactly what we do in our country. And I think it's very important to have this collaboration. You clearly mentioned, Bhaskar, that this technique is feasible for children, but we need to adapt a little bit what we do in adults. I think it's important to know that and to mention what you did really beautifully. My question, Bhaskar, is for a long time, you know, we had to make a choice between shockwave lithotripsy and PCNL, or mini PCNL maybe. Now we have fantastic instruments like these single-user scopes, 7.5, meaning that we can place these endoscopes in all children, more or less. So what is actually the criteria in terms of selection for you, going for shockwave lithotripsy first or going for flexi first?
I think that's a beautiful question, Olivia. And to be honest, I think more than the choice of technique, what is your central good at? You know, what is the strength of your central? Where is most experience in your central? And this is a particular area where rather than quoting guidelines to the patient, you need to look at your own outcome and your own data. And that paper we did with the Indian colleagues, that showed it beautifully. They were very good in mini PCNL, and that was their go-to instrument. We were good in ureteroscopy, and in one of the talks we said, why don't we look at our data individually and compare it? I do think, having said that, if the same logic, if you are a patient, you know, do you want a PCNL or do you want a ureteroscopy? Now, clearly, you want a better stone clearance, no doubt about it. But it's if you do a good PCNL, it's fine, but the chances of major complication with PCNL is always going to be slightly higher than the chances of major complication with the ureteroscopy. For two reasons. One, if the ureter is really tight, you can always stent and come back. And that option isn't really there with the PCNL if you're committed to it. And secondly, with the smaller scopes, the initial problem with pediatric was access. You know, a lot of time there's failure to access. With smaller scope, that problem isn't really there. The failure to access is quite easy, or much easier. And then when you are inside, it is like doing an adult ureteroscopy. So in my mind, if the guidelines say they are similar in adults, why should they be any different in pediatric? That's number one. Number two, in pediatric patients, you have to put them for a general anesthetic usually anyway to give shockwave lithotripsy. If you're going to put them for a general anesthetic, would you want a few sessions under general anesthetic, or would you want one, maximum 2 sessions of general anesthetic and make them stone free? So if I was a patient, you know, or if it was my child, I'd want 1 or 2 sessions, but then they are stone free. You don't have this ambiguity and uncertainty of whether they are going to be stone free or not. So I think flexi-ureteroscopy is probably, as it has become more safer, is probably going to match and probably supersede lithotripsy, even in pediatric patients.
Yeah, thank you, Bhaskar. I think that's exactly what we can, all of us, we can see that we're going more and more for flexi for not only adults, but also in children. That's true.